بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, we will continue the subject of lymphatic imaging, and this is the final talk about the lymphoma. You remember we have finished the lymphoma of the CNS, spinal cord, head and neck, the thorax, the heart, the breast, gastrointestinal tract, liver, spleen, pancreas, and peritoneum. We are left with renal lymphoma, gynecologic lymphomas, and prostate and testicular lymphoma, and finally the musculoskeletal lymphoma. Then the renal lymphoma is in the incidence of 5%, and then of course non-Hodgkin lymphoma is more common than Hodgkin disease, and the origin of renal lymphoma is usually the sequelae of direct extension from retroperitoneal disease, but also hematogenous dissemination can occur. And you know that the primary lymphoma is rare since the kidneys do not have primary lymphatic tissue. Then the radiologic feature of lymphoma in most of the cases is that you have multiple hypodense less enhancing lesions compared to the enhancement of the normal renal parenchyma. The involvement is usually bilateral in about 75% of cases, and the result is diffuse bilateral enlargement of the kidneys. This is the pre-contrast and this is after contrast. Then in many times you can see enlargement of the retroperitoneal lymph nodes. And this is one of the rules in the literature that whenever you are confronted by bilateral multiple renal masses associated with diffuse renal swelling, then you think of renal lymphoma as a first diagnosis. And sometimes the kidney is engulfed by retroperitoneal disease or enlarged lymph nodes, as you see in this example, and this is known as perirenal lymphoma. And the incidence of lymphoma at autopsy is very high, ranges between 30 to 60% in lymphoma patients. The incidence of CT diagnosis of lymphoma is about 5%. The symptoms are flank pain, weight loss, sometimes hematuria, and palpable mass. The most common type of renal lymphoma is the B-cell non-Hodgkin type. And how can you predict renal lymphoma on imaging? These are some of the suggested criteria. Number one, the patient is known to have lymphoma. Number two, the patient is immune compromised. Number three, other lesions beside the lesions in the kidney, especially those in the spleen, a presence of retroperitoneal bulky lymphadenopathy, and this is one of the pathognomonic features, which is multiple bilateral renal masses associated with renal enlargement. And this is a case of bilateral renal lymphoma. The kidneys are enlarged. They are studied by multiple relatively hypodense focal parenchymal lesions, and many times these lesions usually respect the renal contour. They do not disturb the renal contour, similar to what happens with renal cell carcinoma. Renal cell carcinoma presents as a mass which is usually bulging beyond the renal confinement, but here the kidney is enlarged, but the contour is more or less maintained. Then adrenal lymphoma is diagnosed at autopsy in about 25% of the cases. Bilateral involvement of the adrenal glands is more common than unilateral affection. The tumor is usually homogeneously enhanced with no areas of necrosis or calcification. You remember when we discussed the issue of the adrenal glands, we said that bilateral masses in the adrenal glands include so many diagnostic possibilities like lymphoma, metastasis, bilateral pheochromocytoma, bilateral adrenocortical carcinoma, and there are a lot of possibilities, but lymphoma is usually suspected based on the previously mentioned criteria that uh, that suggested the possibility of lymphoma in the kidneys, but in many times you need histologic proof by an imaging guided biopsy. And this is bilateral involvement of the adrenal glands by soft tissue masses, and of course, PET scan is not so much helpful in assessment of this disease since most of the previously mentioned possibilities will show increased metabolic activity. Then you have the follow-up after treatment with almost total regression of the left side and residual small mass on the right side. And this is bilateral adrenal lymphoma with involvement of the pancreatic tail. Of course, you cannot say the diagnosis from this image, but you need some informations about the clinical picture of the patient. And if you don't, if you cannot reach the diagnosis, then you may go for biopsy. Then this is an example of a right adrenal gland mass, left renal focal lesion, and a lesion in the pancreatic head. And these are proved to be related to diffuse B-cell lymphoma. Burkitt lymphoma is an aggressive B-cell type that affects children predominantly. It is considered the most common type of non-Hodgkin lymphoma in childhood, reaching about 40%. The mean age of Burkitt lymphoma in children is around the age of 8 years, with male to female ratio in the range of 4:1. Then Burkitt lymphoma in adults is less common, accounting for about 1 to 2% of lymphoma. Burkitt lymphoma is known to affect many organs in the body. It is also known to have a good prognosis with survival rates more than 90%. Burkitt lymphoma can present by many sites of involvement, including sites in the head and neck, like the facial bones and the Waldeyer ring, the pleural space, gastrointestinal tract, mesentery, peritoneum, retroperitoneum, kidneys, gonads, and nodal involvement is less common in children, but is more common in adults. And this is a case of Burkitt lymphoma in a male 35 years old who is HIV positive, presenting by loss of weight and rectal bleeding with distended abdomen. The section in the chest showed a mass in the right atrium and some pericardial thickening and minimal pleural thickening as well. Lower down, you see a bulky lesion in the left hepatic lobe and two other lesions in the adrenal glands. Lower down, you can see multiple lesions in the kidneys and also a lesion in the pancreatic tail, and this was a, a Burkitt lymphoma affecting the right atrium, the liver, adrenal glands, the kidneys, as well as the pancreatic tail. Then gynecologic lymphomas involves the uterus, especially the cervix, and may affect the ovaries and vagina as well. Uterine involvement is in the range of 1% of patients with lymphoma. At autopsy, the uterine lymphoma is detected in 40 to 50% of patients with lymphoma. The imaging findings of gynecologic lymphomas are considered non-specific, but the lymphoma of the uterus usually preserve the endometrial lining and also the junctional zone. And here is lymphoma of the cervix. The cervix is considered the most common site for lymphoma in the female genital tract, and the age incidence is in the range around the age of 50 years. How can you predict lymphoma compared to cervical carcinoma? These are some of the suggested criteria. Lymphoma has a large size, it do not invade the surrounding structures, it do not show evidence of ulceration. Also, if you can find bulky lymph nodes in the vicinity of the tumor and the nodes are homogeneous with no evidence of necrosis, then you may predict the possibility of lymphoma. Then lymphoma may be mistaken for cervical cancer, which is of course much more common than lymphoma. But if you try to use the suggested criteria of a bulky mass infiltrating the cervix, homogeneously enhanced, with no tendency to invade the bladder or the rectum, for example, then you may think of lymphoma of the cervix. And this is lymphoma of the vagina in a female patient with known history of orbital non-Hodgkin lymphoma. Of course, the presence of lymphoma elsewhere in the body is usually a supportive finding for the diagnosis of lymphoma compared to other possibilities. In here, you see that the vaginal vault is involved by a mass, and this mass is homogeneously enhanced. Then if you look carefully, you see a big lymph node here on the left side, which is also better demonstrated in this MR image. And you see the mass infiltrating the vault of the vagina, and also you can see a lesion which is intimately related to the urinary bladder wall. The diagnosis of non-Hodgkin lymphoma was confirmed by biopsy. And this is a female patient presenting with weight loss and decreased appetite. The scans showed a bulky mass in the region of the cervix with involvement of the uterine body, and also you can see these bulky homogeneously enhanced retroperitoneal lymph nodes. The diagnosis of lymphoma was suggested. And ovarian lymphoma is always a secondary type, and the most commonly of the B cell non-Hodgkin type. The bilateral involvement is more common. And if you remember what I have mentioned considering the Krukenberg tumors of the ovaries, they are usually bilateral, they are usually solid, they are homogeneous, they are relatively small than the primary ovarian carcinomas. Then ovarian lymphoma may simulate the Krukenberg tumor, But in cases of Krukenberg, there is a primary malignancy responsible for these ovarian metastases. And in cases of ovarian lymphoma, you may find in the clinical history a lymphoma elsewhere in the body as well. Then mild contrast enhancement is usually seen, and sometimes or many times you do not see ascites, as you can see in the metastatic ovarian tumors. And this is a proved case of bilateral ovarian lymphoma by CT. You see two masses in both ovaries. The masses are solid. They are almost homogeneous apart from these necrotic areas. And this is the T2 weighted image. You see the two ovarian masses. And then the T1 post contrast with fat suppression. You can see the enhancement. This is almost similar to the Krukenberg metastatic ovarian tumors. And vesical lymphoma is considered rare compared to the urinary bladder carcinoma, and both cannot be discriminated on the basis of imaging, and you need the help of a biopsy. And in this IVB, you see a regular filling defect involving the right lateral wall of the urinary bladder, which is confirmed by CT. And this appearance should be diagnosed as urinary bladder carcinoma until proved otherwise. You cannot say as a first possibility, or even you include this in the differential diagnosis. You may mention lymphoma. No, but you should say first this is urinary bladder cancer, and you recommend an endoscopic verification. Then if it proved to be a lymphoma, then you will not be on the wrong side. And testicular lymphoma accounts for around 10% of testicular malignancies and 2% of non-Hodgkin lymphoma. This is considered the most common bilateral testicular tumor, as seen in about 40% of the cases. And if there is unilateral testicular swelling in a patient above 60 years of age, you may think also of lymphoma. The diffuse large B-cell type of non-Hodgkin lymphoma is the most common, and extranodal involvement is commonly seen, especially the Waldeyer ring, the lung, the skin and subcutaneous tissues, CNS, and of course the contralateral testis. The ultrasound is a modality of choice for evaluation of testicular pathology, and you can see diffuse enlargement of the testicle with ill-defined hypoechoic testicular masses or a single mass, and enlarged hypoechoic epididymis with hypervascularity on color Doppler. And this is the appearance of the normal testis by ultrasound. And if you look here, and you can see that the testicular parenchyma is involved by multiple ill-defined hypoechoic masses compared to this normal homogeneous ecotexture of the testis. On the Doppler study, and you can see hypervascularity of the lesion. And finally, we came to the issue of bone lymphoma, and the uh, average age of presentation is also around the 50 years of age. The lymphoma may present by fever, night sweats, and weight loss, diffuse or dull aching bone pain, as well as fatigue, may also present by pathologic fracture, and in cases of spinal lesions, neurologic deficits may be seen, or in cases of joint affection, effusion of the joint may be identified. This, these are the frequent bones involved by lymphoma, including the femur, the pelvis, the humerus, and the tibia. And here are the Radiologic appearances of lymphoma of the bone, osteolytic lesions in most of the cases, mixed osteolytic and blastic lesions in a good percentage, then osteoblastic or sclerotic lesions is less frequently seen. Also, in the clinical practice, this is stated in the literature, but in the clinical practice, we usually diagnose lymphoma based on the presence of mixed osteolysis and bone sclerosis. And you can see here in the proximal part of the tibia, there is heterogeneous appearance of the bone texture with areas of sclerosis alternating with other areas of osteolysis. In the presence of aggressive, in the absence of aggressive bone destructive changes, periosteal reaction, and the extraosseous soft tissue component, then you may think of bone lymphoma. Bone lymphoma is usually of the non-Hodgkin type, which is about 4 to 5 times more common than Hodgkin disease of the bone. Then these are the manifestations of lymphoma in the bone as seen on imaging: cortical destruction with adjacent soft tissue and muscle involvement, like here you see some cortical disruption of the neck of the humerus with a small extraosseous soft tissue component. Bone sequestra are seen in about 16% of the cases, also seen in osteomyelitis, fibrosarcoma, and Ewing sarcoma, and malignant fibrous histiocytoma. Periosteal reaction is seen in about 47% of the cases, especially in the long bones. Extraosseous soft tissue component is, of course, best identified by MRI. Pathologic fractures are seen in about 20% of the cases, vertebral compression in spinal lesions. And the issue of PET-CT in the evaluation of bone malignancies is somewhat debated. The literature considered PET-CT more sensitive, of course, than gallium scan. And PET-CT is non-specific but sensitive. It is sensitive but non-specific since many of other lesions like inflammatory diseases, hyperplastic bone marrow lesions will show increased metabolic activity. And you cannot say for sure that this belongs to lymphoma or belongs to other type of malignancies or even inflammatory lesions. It's important to note that we may perform the PET-CT after 2 to 3 months following radiotherapy and after 1 month following chemotherapy. But some of the literature indicates that you can use PET-CT at the end of therapy immediately or even during therapy to assess the response of the tumor to the introduced type of therapy. Then PET-CT is not specific for the diagnosis of lymphoma. This plain X-ray of the knee is may be interpreted as normal, but an MRI T1 weighted image, you can see diffuse bone marrow involvement. And this appearance, in my opinion, is one of the highly suggestive uh, appearances on MRI for lymphoma, especially in adults. And if you are able to see some sclerotic appearance in the plain X-ray or the CT scan. On MRI T2 weighted image, the lesion shows increased signal intensity, and of course by PET scan and the bone scan you will see tracer uptake in the region of the lesion. And this is PET-CT of the same case showing marked metabolic activity in the region of the tumor. And this patient is 95 years old, presented by increasing pain and swelling in the thigh. And you see a marrow-infiltrative pathology with extraosseous soft tissue component that is circumferentially surrounding the femoral shaft. If the patient is young, we may think of Ewing sarcoma, but in old patients, you think of metastatic disease and lymphoma, and also other primary tumors that are not frequently encountered in the clinical practice, like fibrosarcoma, for example, or malignant fibrous histiocytoma. Then you need biopsy in most of these cases to reach the diagnosis. Remember that I have mentioned that if you have a destructive lesion involving the iliac bone, together with the presence of some sclerotic reaction and extraosseous soft tissue component, you think of Ewing sarcoma if this is a child, and you think of metastasis if this is an adult. Then here you see a lesion which is involving the left iliac bone with osteolysis and sclerosis. Compare this iliac bone by the opposite one. There is an extraosseous soft tissue component extending into the pelvis as well as in the gluteal region. And this is the appearance by MRI T1 weighted image. You see the bone marrow involvement and the extraosseous soft tissue component. Then, if you see this appearance, this is good for the diagnosis of lymphoma because of the osteolysis and the sclerosis, but metastatic disease is still a possibility, and you will need to verify the nature of the lesion by biopsy. In the spine, one of the differential diagnoses of sclerotic vertebrae are the lymphoma, metastatic disease, and Paget disease. And you remember that we can exclude Paget on the basis of the size of the affected vertebra. If the vertebra is enlarged compared to that above 8 or below 8, then you may think of Paget. But if the vertebral body is in the range, the similar size to the adjacent vertebrae, then you are in the differential diagnosis between metastasis and lymphoma. If the patient is known to have a primary malignancy, then you think of metastasis. If the patient is known to have lymphoma, then you diagnose lymphoma. The secondary lymphoma of the bone is much more common than the primary lymphomas. It affects the skeleton in about 15% of the cases of disseminated lymphoma. In this example, this is T1, and this is T1 post-contrast fat suppressed image. See destructive lesion in L4 vertebra and a smaller region at L3 with a very big extraosseous soft tissue component. And you can easily appreciate that the disc spaces, this one and this one, are not involved. Then the diagnosis is between metastasis and lymphoma, and you need the help of biopsy to confirm the diagnosis. Muscle lymphoma is rare, representing less than 2% of all lymphomas and is usually of the non-Hodgkin type. The age of presentation is around 70 years of age. Then the differential diagnosis of a mass in the muscle may include metastatic disease, primary disease like rhabdomyosarcoma, extraskeletal Ewing sarcoma, muscle lymphoma, and sometimes infection like myositis. And this example of a female 70 years old with a right thigh mass lasting for 2 months, and you see an MRI T1, a mass of the medial group of the muscles, and in the T1 post-contrast fat suppressed image, you see some enhancement, and this is the stir image of bright signal of the lesion with stranding of the subcutaneous fat. Then the diagnosis, of course, is confirmed by biopsy. And this has been proved to be a lymphoma of the tibialis posterior muscle. On CT scan, we see a relative hypodense mass, which showed bright signal on T2 weighted image and some enhancement in the uh, uh, no, this is T2 weighted image also, and you see the brightness of the lesion. Finally, lymphoma can affect the skin and is known as mycosis fungoides, and patients often have a history of eczematous lesion in the skin or localized dermatitis that is not responding to treatment. The skin lesion may progress to a patch or plaque or even a skin swelling, and in the later stages, it may be associated with lymphadenopathy and visceral or internal organ involvement. Pulmonary and the CNS involvement can be seen in 14% of cases with cutaneous lymphoma. Thank you very much. Alhamdulillah.